Hi, everyone. Thank you for joining the Reframing Eye Care podcast. I am your host, Dr. Maria Sampoulos. I have Dr. Leslie O'Dell and Rachel Krug from Virtual Field with us today. Thank you both for taking the time to join the podcast.
Thanks for having us.
Yeah, thanks so much.
For our listeners today, we're going to be talking about Virtual Field and how it provides exceptional eye care experience with Virtual Field, color vision, pupillometry exams, and making it comfortable and patient-friendly headset. So there is a growing demand for eye care, and so there is a shortage of ophthalmologists, and us as optometrists can really play a pivotal role in filling some of those medical needs and helping provide comprehensive eye care for our patients. So this is the agenda for today and what we'll go through. And Dr. O'Dell is, our expert for today's podcast to really go into all this agenda and give us some information on these as well. And, Rachel, who is the CEO of Virtual Field, to give us some information as well on how this company is a lot different than other virtual headsets.
Thank you.
So 84% of the population, in the U.S. drives. So car accidents are the leading cause of death. How can optometry play a role in reducing driving accidents?
Well, this one I think is sensitive for many of us because independence is often linked to your ability to drive. That might look a little bit different for you having great access to public transportation, I'd assume, in New York. But, sometimes in more rural parts of the country, being able to drive yourself to your doctor appointment or being able to drive yourself to a grocery store as you are visually impaired and oftentimes an older population of our patients, it can be pretty devastating if there isn't a support system for them. So what you want to know is really what your state laws mandate. In some states, it mandates that if your patient should not be driving, that you are doing some of that reporting. In other states, it might be the physician that has to do that. And sometimes it's a combination of these things. But usually there is some reporting that needs to be done, and good for us, visual field and peripheral vision is part of that. So I can only speak to what's happening in my state here in Pennsylvania. But in Pennsylvania, it's sort of a lottery over the age of 65 that patients will be selected randomly for a more thorough exam. And part of that is acuity measurement. It's also their peripheral vision. But instead of me just checking a box like they can count fingers, peripherally, because it doesn't really tell me what their degree truly is. I offer up an Esterman binocular visual field. And so that allows me to be able to confidently know what defects I'm dealing with, especially in patients maybe who have suffered a stroke in the past or maybe a glaucoma patient.
Excellent. Can you give us a little more information on the Esterman exam?
So the Esterman exam often is not covered by major medical insurance. So it's a lot of times something that patients do elect to pay for out of pocket, and you can set the fee appropriately in your practice. But it's the only binocular, I think, the only binocular visual field that we're running in practice. And so it's able to assess up to 130 degrees on the horizontal visual plane, or actually over 130 degrees when you're considering the binocular range of that. And again, I don't only do this in my patients that are up for their driver's license renewal, or maybe there's been a question from a family member. I also use this test when I have a patient that unfortunately had a life change, like a stroke or something along those lines, so that I know how much visual impairment they have suffered, and is that going to impact their ability for independent driving in the future.
Excellent. Can you give us some, testing that you would do to ensure efficient referral for oculoplastics?
So oculoplastics, I think, is, really, when you talk about, what you spoke of at the beginning, that there is a need for eye care, there is such a shortage of certain specialties. And again, it's probably geographically limited as well. But for me, in my area, oculoplastics are hard to come by. My patients have to drive typically 40 minutes to an hour to get to a good oculoplastic surgeon, or really to an oculoplastic surgeon. So anything I can do in my practice ahead of a referral is going to save my patient time, make the referral a smart referral, I guess. And what I mean by that is, nothing worse than sending a patient to an oculoplastic specialist and getting a letter back that says they have to treat their blepharitis and they're not going to have surgery or something along those lines, which I have seen a fair amount of times. So the visual field, when you're thinking about oculoplastics, really is a great step, because you can send that along with any correspondence before your patient goes for their exam. So, for example, highlighting ptosis, you can really show through superior visual field mapping, taped and untaped, how severe the impairment is in that superior quadrant. And if they were surgically enhanced, by using tape or holding the lid up, you can kind of simulate how much better their superior visual field will look. And that kind of starts the conversation, I think, not only with my patient, but also, with the surgeon, so they know what they're dealing with, even, ahead of the patient encounter.
Oh, excellent. So I want to transfer it over. Here's the images that you were talking about there.
And the other one I just wanted to highlight is just thyroid eye disease, right? So 2020 marked the first year that we had a therapeutic with Tepezza for being able to treat active thyroid eye disease. And I think, they're looking toward chronic disease as well. But those patients really only were able to have orbital decompression ahead of that medication. So we're talking about life-changing medicine. And again, for me, a lot of that gatekeeping is through my oculoplastics. But why a visual field in your thyroid eye disease patients isn't so much for EOM movements or double vision, right? It's really to allow you to know how well the optic nerve is performing. Because again, as the eye is shifting forward, you worry about compression to the nerve.
Rachel, can you speak on how virtual field, particularly VF3 Pro, aids in this protocol for oculoplastics, and how it's important for eye tracking and in this context?
Of course. So we have the Superior 36 exam on both our basic and Pro models. The Pro is an awesome experience, though, for anybody who is running the Superior 36 exam. The taping protocol aligns with the standard diagnostic procedure, but the Pro's eye tracking feature, it actually has a camera, so it allows the doctor or technician to actively monitor the tape's placement in real time. You can make immediate observations, including whether patients are intentionally widening their eyes, potentially influencing test results.
Excellent. Thank you. Go to the next slide here. So what's the difference, Dr. O'Dell, in utilizing it between the glaucoma suspect and the diagnosed patient?
Well, I think really the point I wanted to make when we're talking about glaucoma measurement is for doctors that are interested in starting more into medical optometry and really understanding the value of visual field testing. So visual field testing is very valuable even in your glaucoma suspect. And that's because you can really help build a good foundation for following a patient, but also feel confident that there is no vision impairment and those patients still are living in the suspect part of the disease or just at risk. Once you start, so typically those patients I will annually, or depends on my risk ratio, I guess. Sometimes I might do it even maybe once every 2 years, but typically I'm doing a visual field once a year on a glaucoma suspect. But when I have the diagnosis of glaucoma, there's a couple things that I wanted to talk about with visual field testing. One is the ability to eventually have a probability map, something that's going to help you try to predict the future. Because remember, glaucoma is a lifelong disease. Once we make that diagnosis, we're on the journey with our patients for their lifetime. And we want to make sure that our treatments are setting them up for the best success that we can at protecting and preserving visual function over their lifetime. So having something that is a probability mapping is very, very useful for me when I'm watching glaucoma long-term, but you don't get that initially, with your first test. Usually you need to have 3 to 5 exams that then can start this system thinking ahead for you. So sometimes I might do my glaucoma visual field testing on a 3 to 6 month interval. Now, the tricky part with that is I might not be able to always bill for every one of those, just because each insurance has their own standard of care. Typically 6 months to 12 months is what they're looking at. But the other thing I wanted to talk about was just the type of test that you're doing on a glaucoma patient. And that is the difference between a 24-2, which has really become our standard way of watching glaucoma progression, and then also the 10-2. So over the past maybe 5 or 6 years, a lot has come out around alternating these tests, especially if you have any central points on your 24-2. So even if you just have one box that's black or, within that indices that is of concern, you want to bring that patient back into a 10-2. And the reason is the degree of spacing is so different between those central points on a 24-2 and what you're getting when you're just focused on that central 10-2.
Excellent. So I want to ask Rachel, how does virtual field support the progression of reporting glaucoma patients? So I think that's important for this and for the doctors listening on how this really differentiates it from other equipment.
Sure thing. So as you can see on the slide, we do offer progression analysis with a concise report generated from just 2 threshold exams in the same eye. And so this streamlined process and this report that gets generated automatically for you lets you closely monitor patients and make timely decisions in managing glaucoma.
Well, right there, actually, Rachel, you highlighted something that's very unique if you say 2 exams, right? So that definitely is a differentiator for sure.
Yes. Thank you.
So I want to pass it back to Dr. O'Dell here. There's a lot of systemic diseases with patients that are put on Plaquenil. So what are some common practices? How do they figure out the protocol for these patients?
Well, again, a lot of this, first of all, you're absolutely right. Plaquenil is a very commonly prescribed medication, oftentimes by rheumatology. Sometimes that might be by endocrinology or even primary care providers. But it runs the gamut of just inflammatory conditions to things that we kind of think of when we hear Plaquenil, which would maybe be lupus or rheumatoid arthritis. This medication, when tolerated well by patients and helping reduce symptoms, is something that you will find your patients stay on for quite some time. So I have patients now that have been on Plaquenil for 20 plus years because it's been working better than some of the newer medications, or maybe they're trying to avoid biologics when it comes to controlling their systemic inflammation, but it's not without risk. And, what's been really great to see is the alliance between these specialties outside of eye care with optometry, and ophthalmology in referring patients to us for these screenings. So a lot of times what that looks like is rheumatology will send patients ahead of starting Plaquenil and want their baseline testing, which is typically fundus and autofluorescence photography, a baseline macular OCT, and then a 10-2 visual field. And then it's kind of dependent on dose. So this is a medication that is a quantitative effect on the body over years. So the longer a patient's using it, the more at risk we are for finding ocular findings. Typically, that risk is stronger beginning around 7 years, depending on the weight of your patient and the dosage of your patient as well. But that doesn't mean that you screen them once and then you wait 7 years. Typically, it's once a year in those first 5 years. And then I think it starts to happen around every 6 months. Usually you do need some kind of referral depending on medical insurance. It's easy to get. And again, because the specialties on the non-eye care side of things are very interested in this, it makes it easy to get the referrals.
So I want to transfer it over now to Rachel. And ask like with the medication screenings, how does virtual field contribute to, drug assessments for systemic risks such as plaquenil, and what's its role in detecting, toxicity?
Sure. So virtual field does offer a 10-2 with a red stimulus, and that provides a targeted examination of the central visual field. And this is particularly valuable for detecting optic toxicity associated with medications and contributing to the comprehensive evaluation that Dr. O'Dell was speaking about.
So, Dr. O'Dell, we have a lot of patients that have, diabetes, macular degeneration. What role does, virtual field test play with these patients?
Well, I think it's interesting if you actually look at the CMS reasons why you would run a visual field, the list is quite extensive. And some of the reasons we might not have thought about, one of which is macular edema, whether it's related to diabetic disease or maybe you're dealing with CME in a post-cataract patient. So first of all, my first thing is it's supported. It's a billable thing that you can do. But more importantly, the data you're going to gain from, again, a central 10-2 in these patients is going to help you better understand the functional vision that your patients are experiencing. So letters on a chart are one way that we can measure functional vision. But what we're learning with things, especially the big developments that we've had over the course of the past year with measurements of geographic atrophy, new treatments that have come into that space, measuring acuity on a patient with geographic atrophy is not really that helpful because they could completely miss the center letters and and see the letters on either side of central. And you might think, oh, I still think that patient sees 20/40 without realizing that they have a giant scotoma right in the middle, right? Because you can't really see that. When you map out a 10-2 on a patient with GA or macular edema, for whatever reason, the edema is caused by, you get a better idea of what's the visual function, and it's kind of an addition to what you're doing with your acuity measurement. And I think what you can do is see how it may improve as you maybe partner with a retina specialist and start treatment, especially on diabetic macular edema, for example, and see if you regain visual function as you would anticipate.
So kind of switching over to the neuro aspect, migraines are very common. What workup would you recommend for this type of patient? I usually run a field, but what is your protocol?
So I do too. And what I really love about, what virtual field has to offer is the other things that really matter to me when I'm looking at a migraine patient is pupil measurement. So I really want to know that I have a very accurate pupil measurement, and pupillometry. I've used pupillometry before in some clinical research, really looking at dilation reversal. And it's amazing how much more accurate the measurements are when you're using pupillometry versus your pen light and, you're holding up your little card to see, okay, this is, a 6 or a 4 or whatever your measurement is. So pupils matter. Sometimes that's because in a migraine patient, you could at times see a spontaneous dilation of just one pupil. And obviously unilateral pupil dilation on a patient is a cause for alarm, when that enters into our practice. So again, knowing what your baseline measurements are, super valuable for being able to monitor a patient over time. I also really like having color vision on my migraine patients because it helps me know not only macular health, but what the optic nerve health is. And so oftentimes if I, have a color deficit, I know, again, that's my first tip off to really be paying attention again to the pupil measurement and then ultimately the visual field when I'm thinking things, not just migraine, but in the neuro space. But visual field is so important. And, the reason why is because migraines have that hallmark for causing peripheral vision complications, whether it's the scintillating scotoma, sometimes it could be almost like a hemianopsia, but it's super alarming for patients when they have that. And to be able to give them peace of mind, because oftentimes it does restore to normal, is also good just for helping them feel a little bit less angst around that condition.
So I want to ask Rachel here, how can you elaborate on current experience with virtual field and what it offers?
Sure. So what we see here is all of the different exams that we offer and the CPT codes. But at Virtual Field, we really think about what we offer even more elevated than this as an experience where we put the doctor, patient, and technician in, keep them in mind and put them first. So we are proven. Virtual Field was the first virtual reality visual field technology on the market, and we've been on the market since 2018. And our doctors have actually just completed over 1 million exams. So that's a very exciting milestone for us. Everything is comfortable, intentionally designed with the patient and the provider in mind, easy to use. We're also very caring. We support eye care teams every step of the way. Our customers receive a free onboarding call and ongoing email and phone support with live agents. And then we're really innovative, and we like to build based on customer and market feedback. So, open to people's feedback. We're always adding new exams, like the Kinetic Visual Field Goldman exam we just added into our Pro package. So, whether you're running a visual field exam or viewing reports or another type of eye care exam, we're really here for you every step of the way. And we do offer a free 30-day trial that you can sign up for on our website at virtualfield.io. So feel free to sign up there or sign up for a demo and ask the team any questions.
Excellent. So for those of you that have questions, you can refer here to this email or call Virtual Field.
I also just wanted to say one last thing myself, Maria, before you wrap up. I wanted to say how, remember the days when you were in, school as a student and, your job was running visual fields. Like you spent your day in the dark, running visual fields on patients that sometimes took a very long time to even walk down the hallway to get into the closet that the visual field machine was housed in. It's amazing to see these headsets and also really just the patient adoption to them, patients that have not really ever been in a virtual reality setting that are able to adapt easily. So it takes so much stress off of the clinic, the staff, because it can be done anywhere. It doesn't have to be done in the dark. And it really allows us to really, as medical optometrists, really utilize the value of a visual field. When I'm running visual fields, sometimes I will say to patients, this is my first step in figuring out, what else we need to do. Sometimes I will call it the MRI of the eye exam because it helps me know how your visual system's communicating with your brain. And so I'm really just excited that with ease of use, we're going to continue to see this testing just grow and grow within our practices.
No, it's been a great addition to my practice. I have it in my office. My staff has been very open to it. Patients see it as a wow factor. And it's been a great way to also multitask if we have to do a field and not have a lot of space. And I think a lot of doctors are struggling with space requirements and things like that. And I think that's been a great way as well to incorporate into the practice. So, and it's very affordable. That's one of the things too that, I thought was, I have great technology, but it's also something that we can incorporate without a big investment. So that was a really important factor for my practice. So I want to thank you both, Dr. O'Dell and Rachel, the CEO of Virtual Field, for coming on, for taking the time to giving some information. If anyone has, again, any questions, please email sales@virtualfield.io or you can call them. Thank you so much for coming on the podcast.